attention to this because it's a wonderful talk. Um, just a little bit about Dr. Skhiri. Dr. Mehdi Skhiri is a clinical assistant professor of medicine in the Department of Primary Care and Population Health at Stanford University, with a focus on medicine, primary care, and population health, as well as other specialties such as cardiology and insulin resistance. Dr. Skhiri is dedicated to improving health outcomes through comprehensive care and innovative approaches. He is also affiliated with the Stanford Cardiovascular Institute, where he contributes to advancing cardiovascular health initiatives. Dr. Skhiri earned his medical degree from Paris. His extensive training and expertise enables him to address complex health issues and promotes wellness within diverse populations. Through his work, he aims to enhance the quality of care and fosters healthier communities and healthier patients. We are grateful to Dr. Skhiri. This is his second talk for us, and for his contributions to our wellness seminars, and for consistently teaching us all the best way to advocate for ourselves and our loved ones to promote healthier lives and healthier and happier lives. So thank you, Dr. Skhiri, and we look forward to hearing your lecture.
Thank you, Anna. Thank you for the nice introduction. Let me start by sharing my screen. Let me do that. Okay. And okay. Can you see everything, Anna?
Oh, yeah, I can. It's great.
Very good. So, Anna, I do agree with you. Today, it's a talk about South Asian people or people of South Asian ancestry. It could apply to many other ones. The same idea, the one we had in November about fibers. We chose one fiber just as an introduction to what the world of fibers is. And here it's an introduction of the world of more advanced primary care preventative medicine and using a very specific population. And I will explain to you why right now. So no disclosures, I have no conflict of interest, no affiliation with the industry. So what is topic today? So I worked in a clinic, a Stanford clinic for 5 or 6 years, where the population I was seeing was mainly from South Asia, I would say 80 to 90%. And during those 6 years there, I witnessed one MI in a young person of 32 years old. I heard about another MI of someone 42. I heard about cousins of my patients passing away at 31. So obviously something was happening within the South Asian population, and that's where I started trying to understand what we could do better in primary care for them. And that's so after those many years taking care of South Asian people, I'm sharing here guidelines, but also my own experience. So let's address the elephant in the room. So that's the elephant of my daughter. And actually, it's my son's birthday today. So happy birthday, my son. So let's see this elephant. So in 2013, the American Heart Association and the American College of Cardiology developed a calculator to predict cardiovascular risk or the risk of any cardiovascular event at 10 years. And they used races for that. And interestingly, they used white, African American, or other. Maybe because it was a very small cohort. But that's what the calculator we had up to recently. If we compare with other calculators from other countries, in Europe, without the UK, they use a score that actually doesn't include any race or ethnicity, but talks about region of origin. And they also include the countries that are surrounding Europe, so like countries in North Africa or even all the way to Russia. In the UK, they have a really big database from the public healthcare system, and so they can really disaggregate the data, and they have 7 ethnicities, no race. In 2023, the American Heart Association and ACC, they reversed they take on races, and they eliminated any reference to race or ethnicities. As a result, the new model, the PREVENT model, does not include any origin, and instead they seem to be focusing on the social economic status, which, by the way, in the UK, they have been doing it for some years already. But at the same time, they did acknowledge that the disaggregated data were not relevant to South Asia, and probably underestimating the cardiovascular risk for them. So what is the elephant in the room? It's really simple. Races do not exist. It's complete human construction, has nothing to do with science. And since we all have parents, we all come from two parents, I'll be talking of ancestry today. So today we're talking of South Asian ancestry patients. So what is the definition of South Asia? There is not one, actually. We all agree it's all around India. Most people include India, Pakistan, Nepal, Bangladesh, Bhutan, Myanmar, Sri Lanka, Maldives, and Nepal. Some people add Afghanistan to it. We're not going to debate this, but that's the idea. This area of the world we're going to talk about. So let's start with the first study. So this is a study from Northern California, for Kaiser actually, when they looked at more than 250,000 patients of Asian ancestry, so patients in the USA. And they compared the different subgroups within Asians. And just to show the discrepancies in terms of health risk for all of them. So in the red box, you have the South Asians, and the South Asians compared to other Asians have an increased risk of diabetes. The hypertension risk seems to be at baseline average. The risk of coronary artery disease is increased, the risk of obesity is increased, and the risk of smoking is decreased. And smoking, it's easily explained. But South Asian are not, they have increased risk, but they're not the only one. For example, if you look at the Filipinos have an increased risk of everything. When at the same time, people from Chinese ancestry favors decrease of everything. So there's really subgroups within Asians, and it's a bit unfair not to individualize each group in order to provide the best care possible. So that's what we're going to try to do today. So we talk about diabetes and coronary artery disease in South Asia. There's another condition we're going to talk about tonight. It's fatty liver. What they have in common, fatty liver, diabetes, and coronary artery disease, they can be silent for a long time. And they can be silent until we have a complication. The complication with coronary artery disease is a heart attack or the angina. Complication with diabetes could be any complication of diabetes, and the same with fatty liver or metabolic steatosis. So if you look on the left-hand side, the world with the prevalence of fatty liver, we see that in South Asia, it's somewhere between 30 and 45% of people that have fatty liver. It's on the high end of the spectrum. And on the right-hand side, if you look more specifically to people with diabetes, how many have fatty liver? In South Asia, it's between 55 and 65%. So we have at baseline around 30-35% of population of South Asian ancestry that may have fatty liver, and if they had diabetes, it's more than half. So those are three silent conditions we're going to talk about today. And since today it's a diabetic lecture round, we're going to start with diabetes. And you see, actually, that's one of the most complex topics. Then we talk about fatty liver, newly renamed MASLD, and we will finish with the cardiovascular risk, which is actually, I think, the easiest one. You may hear during the presentation different studies I mentioned. The two main ones are the MASLD study, so that's a study that originated at UCSF. They had 3 rounds, I think, up to now, on new patients. So they at least have 1,100 participants, I think 1,164. The Interheart study, it's a study that included 52 countries, And you see with a good number of people from India and Pakistan and Bangladesh. And the MESA study is a study from the USA, and it's more like a control for when we talk, and you see it's often used as a control. It mainly includes white, black, Hispanic, and Chinese. I'm just writing the way it was written in the paper. So let's start with diabetes, and the first one will be definition, then challenges exactly with those definitions. And of course, what's really more relevant to tonight's talk, it's what any people from South Asia should be asking their doctor to do for them. So the definition from the American Diabetes Association, there's 3 stages. The normal stage, people with no diabetes, a stage before diabetes, sometimes called pre-diabetes, and a stage called diabetes. So the stage called diabetes can be diagnosed in 3 different ways. One with the elevated fasting glucose, that's one way. Another one with an elevated post-glucose challenge. So that means we give glucose to someone, and if the glucose level goes too high in the blood, then it's a definition of diabetes. Or we can do an average of those two, and that would be the A1C, which reflects an average of 3 months of glucose in the blood. So you see already right away, you can tell there's like really 3 different metrics that may not overlap properly. So let's see what we know about South Asian people and those 3 metrics. So my first study here is a study from Bangladesh. And you see on the left-hand side, they compare the fasting glucose versus the glucose challenge, that's the horizontal row. In the perfect world, if there were a great correlation between those 2 metrics, the diagonal will be 100% everywhere. So the first diagonal, the first square, you see the correspondence, it's only 94.8%. So that means when someone is labeled as normal by fasting, we will miss about 5% of them that will have either pre-diabetes or diabetes. The discrepancy, doesn't get better. For pre-diabetes, the correspondence between those 2 tests, it's only of 22.3%. And when we go to diabetes, it's only 71%. That means that when someone diagnosed with a fasting glucose meeting the criteria for diabetes, when we do the 2-hour glucose test, there will be only 71% of them that will be confirmed. So you see those tests are not equivalent. That's something really to remember, and that's relevant to all of us when we see our doctor actually. Another way to look at it, so now we're moving to India, to Chennai, East Coast. They have a few papers coming for the same study, the Chennai Urban Rural Epidemiology Study, and they looked at the significance of A1C versus the other test. And so they showed it's really similar to what we just saw, but A1C of 6.1%, which would be pre-diabetes, predict a diabetic glucose test, a positive glucose test challenge. When it comes about the fasting, the A1C would be 6.4, so close to the same diagnosis. Those numbers, they're not only numbers like which number is right, which number is wrong. They do have some clinical implications. So this one, we're moving to the urban Chennai, so that's another study. And look on the right-hand side. So in blue, if someone is diagnosed with pre-diabetes by fasting glucose, the risk of conversion to diabetes per year is 8.6%. But if we diagnose someone with pre-diabetes, but this one by glucose challenge test, the rate of transition is increased by 50%, almost 14% a year. So the numbers don't reflect the same things and don't imply the same things. So this was just to try to show you that look at those numbers with a critical eye. Yeah, one number doesn't mean everything. Then when we're talking about diabetes and redefining numbers, I was wondering if I should make a slide just on BMI, but actually I'm going to include this one, including this slide to the diabetes chapter. So this is another study that included 2 big surveys, and they looked at which BMI the risk of diabetes increases. And by adjusting for different parameters such as age or gender, they showed that the risk of diabetes in South Asian people, or at least in Indian South Asian people, the risk increases at 21.8. So just as a reminder, in the USA, and that's also a WHO definition, obesity starts, overweight starts at 25, obesity at 30. So that means the risk of diabetes starts at a much lower BMI than it does based on the current definitions. And actually, the definition of overweight and diabetes in Asia and in India in particular are different. The same in China, the same in Korea. But in China, in Asia, in India, the definition for being overweight starts at 23, not 25 like in the USA. And actually, the definition of obesity, I found different numbers going from 25 or 27. So some people, if you're from Asia, 25 definition of obesity, when here in the USA, it's the beginning of the definition of overweight. So also, if you're from South Asia, look at your BMI very carefully. It's not the same as the one we have in all the guidelines here in the USA, even if they start to change a bit. So let's be practical. Now we have deconstructed all those numbers and all those BMIs, and we're starting from a fresh blank page. So when you see your doctor, the thing you should be asking, and at the annual visit once a year, would be a fasting glucose and A1C. Many doctors don't do fasting testing anymore. I think they're still relevant, especially because you can compare fasting glucose and A1C. That would give you two metrics for diabetes instead of one, would be A1C. If both are concordant, so that means they both show non-diabetes or both show pre-diabetes or diabetes, I think this is it. I would call it pre-diabetes or diabetes or non-diabetic at all. But if you start having some discrepancies, one is high, one is low, especially the fasting glucose is low, but the A1C is elevated. That means there's maybe some elevated sugar after eating or after ingestion of any type of food. That's when one could consider asking for a glucose tolerance test. So that's a 2-hour test when they give 75 grams of glucose to someone fasting, and they check the glucose after 2 hours. Some cases where the OGTT is mandatory, everybody that has been pregnant knows about that. It's pregnancy. But there is also other condition when the OGTT is the best test. And actually, when we talk about treatment of diabetes, I think the studies, most of the studies were based on the OGTT, the glucose tolerance test. So start with those two tests, and then what to do with those tests. So that's beyond the guidelines. So you won't find in the guideline those calculators. I really like calculators. I find them very useful. When after someone does the annual visit lab and they have the results, what they can run, it's really easy, it's online. There's something called Q Diabetes 2018. So that's the calculator from the same database I mentioned earlier with the second slide, the one from the UK. It includes 150,000 patients or people from South Asia living in the UK. So a similar situation as South Asian living in the USA in terms of modern food. And it's really interesting because it predicts the risk of having type 2 diabetes within the 10 next years. It's pretty easy to calculate, and it can be eye-opening, actually. I used it a lot. I don't use it as much anymore because I moved on from my clinic, but I used it a lot, and it's very a powerful test. Another way to estimate the risk of diabetes would be a really new index called the triglyceride glucose index. It's kind of the new kid on the block. It may replace another one, an old one, the HOMA. I like the triglyceride glucose index because it really uses something really simple, fasting glucose and fasting triglyceride. Those are two tests we can get every year, paid by the insurance companies during an annual visit. Unfortunately, we still don't have clear cutoff numbers for all the population. The strongest study I found so far was one for Mexico, and it showed that a score of 4.5, 4.6 can predict the existence of insulin resistance in patients. And they used a gold standard method, a clamp method, which frankly it's only done in research. I did not find anything just specifically on South Asian. I found another cutoff in East Asian population, I think a Korean population, where 8.6 or 8.6 cutoff could predict the occurrence of diabetes. So something similar to Q diabetes, but not as well standardized. So since we don't have cutoff, the way to use the triglyceride glucose index would be to compare year after year with the previous number and see the trend. So if someone sees like they were 3.5 the year before and now they're 4.5 and following year 5.5, they know they probably have some insulin resistance building up. And just a matter of time before seeing like impaired glucose tolerance and there maybe diabetes. And then the last test, the last calculator, frankly, I don't really use it. It's more relevant for population data. It's the HOMA. There's a HOMA IR, there's a HOMA beta, there's different one. This one uses fasting glucose, fasting insulin. Fasting insulin is not done routinely. If someone wants it, they have to ask for it specifically. And I'm not so sure how it's covered by the insurance, by all the insurances we have here. So just to summarize what to do with diabetes. So start with something really simple, A1C, fasting glucose, fasting triglyceride, done at the annual checkup. So that means it's all covered by the insurance. And then calculate at home the Q diabetes and the triglyceride glucose index. If there's any concern or eccentricities, fasting insulin can be considered, but the 2-hour OGTT could also be done, especially I would say for people with the A1C, let's say between 6.1 and 6.4. So remember the Bangladesh study showed that there's a good chance to be diagnosed with diabetes if we're on this range. And that also explains, and it's really important to be diagnosed with diabetes early on for all the complications. There's a study that showed that we don't have to be, one doesn't have to be diagnosed with diabetes based on the A1C to start developing complications, especially microvascular complications. So that would be kidneys and retina, eye. So that's the way I would do it. Really simple. Just remember 3 things, 2 calculators, and see what you think or your doctor thinks. All right, let's take a big breath, and I'm going to take a sip of water. So the second chapter, it's on fatty liver. So fatty liver, that's the term everybody knows. For physicians, we call that hepatic steatosis. It can be triggered by any conditions, but when it's due to a metabolism or dysmetabolism, it's called MASLD. So again, it's also a silent condition. The gold standard used to be liver biopsy. Thanks God we don't do that much anymore. Imaging can replace liver biopsies. You have on the right-hand side the criteria for metabolic syndrome or dysfunction, the one used by the American Association of Study of Liver Disease. And you see they take into consideration where the patients come. So a BMI 25 for everybody, but if someone's from Asia, the BMI drops to 23. And so you see there's a question of being overweight, high sugar or not, high blood pressure or not, increased triglyceride, and increased non-HDL cholesterol. So when someone has like fatty liver plus those criteria, it's called MASLD. And the fatty liver term, it's a bit misleading. It's almost like I have fatty cheek. It's almost funny. Actually, it's not funny at all. This condition comes with a risk of liver fibrosis. So you start with a steatosis, so increased fat to the liver, and then slowly fibrosis develops, different stages, and the last stage being cirrhosis. Cirrhosis and liver failure, liver cancer. So this is one of the complications from this condition. The rate of transition from one stage to another is not well established. It's around 7-9 years. Some studies have shown it could be as fast as 4 years. So that means every year someone will change one fibrosis stage. And it's not all. It also increases other conditions such as cardiovascular disease and non-hepatic malignancies. So it's really a whole picture of coming with diabetes and metabolism or dysmetabolism. That's the term I prefer. So this chapter is the shortest one, only a few slides, but actually it could be one of the most complicated one. I'm just going to give you an idea of what we're going to do right now. So the current guidelines, I think they were published last year. They go from suspicion of MASLD, and from there we test for complications. When traditionally in medicine we have suspicion for something, we establish the diagnosis, and then we test for complications. And actually, in this one, it's really a kind of a revolution, a way of thinking in medicine. You say, don't lose too much time on the cause, make sure there is the complication, or to establish, make sure there's no complication. And I'll show you how we do it. So when to suspect MASLD, so it's some really specific populations. So non-MASLD by imaging. So if someone gets an ultrasound for another reason, abdominal pain, and they find that the liver is hyperechogenic, they would say fatty liver. It can be seen on CT scan, MRI. That's a no-brainer. It's easy. I mean, it's short, so the diagnosis here, but you don't have to. It could be on people overweight, so BMI greater than 23 in Asians. Family history of liver cirrhosis due to MASLD, type 2 diabetes, or even pre-diabetes, or just clinically suspected MASLD based on the criteria we just saw 2 slides ago. Could also be on elevation of liver enzymes. I mean, it's based on a suspicion. So when we suspect that may be some fatty liver, we're not going to diagnose it. We're going to make sure there's no fibrosis. So the way to do that, we use a blood test first. The blood test first should include liver enzymes and platelet count. This is also in the annual checkup labs. So it's no additional labs. You don't have to ask anything for your doctor to do for you. It's just included. I mean, most of the time. And then from that, the doctor can calculate a FIB-4 score if you're between 35 and 65. It was not validated before 35, and after 65, the cutoff is a bit different. But let's say between this age, between 35 and 65, if the FIB-4 score is greater than 1.3, then you should ask your doctor to do a fibroscan. Fibroscan, that's sort of an ultrasound you see below to the right-hand side. It's really simple. It measures the stiffness of the liver and gives a very good information. One on the stiffness of the liver, so that correlates with the fibrosis of the liver, but also on the content of fat. So you get 2 results with the fibroscan, how much of fatty infiltrate we have to the liver and how much of fibrosis we have. And that can save lives. So that's what to do. So just to summarize, with your next annual visit, if you think you fall in any of those categories, overweight, diabetes, pre-diabetes, etc., ask your doctor to do your liver enzyme and your platelet count and do the FIB-4. You can do it yourself. They can do it for you. And if it's greater than 1.3, ask for a fibroscan. Fibroscan is not that expensive. If it's negative, you can repeat it 3 years later. If you're below 35, younger than 35 or older than 65, it's a bit different. The cutoff is different. 35, there is no validation, so it would be a case-by-case discussion. 65, they use a different cutoff. But as patients go to 90, of course, the FIB-4 is exponential. So at one point, it doesn't make sense to use the FIB-4 anymore. But so 35, 65, just calculate your FIB-4 with your annual labs. And that may make a big difference to your life. All right, let's take a second breath and we do the last chapter. And I have another sip. So the third chapter, it's on cardiovascular. So cardiovascular, I'm doing a reference to a movie from 1966. I don't know if people recognize it. But we used to say in medicine that the cholesterol, we measure HDL, LDL, one was the good one was the bad one. Well, we need cholesterol to live, so a bad one can be a bad one when it's necessary. But then I like this movie. It's called The Good, the Bad, and the Ugly. And in modern lipidology, we shouldn't be talking of HDL, LDL, and we should be talking of ApoA1, ApoB, and LPA, at least. The ApoA1 is mainly found on the HDL, so that used to be the good guy. So now I named ApoA1 as a good guy. ApoB, it's found on different particles, LDL, VLDL, LDL, PA, and chylomicrons, but it's a major component of LDL, and then explain the negative role of LDL to our arteries. And then the LPA, the way to see LPA, it's a lipoprotein A. It's a type of LDL on steroids. So it's more atherogenic than the LDL itself. It has an ApoB attached to an ApoA, not ApoA1, ApoA, and that makes it very atherogenic and pro-inflammatory and pro-thrombogenic. So it can make blood clots, increase inflammation, and increase the plaques in our arteries. And that's what I call the lipid risk or lipidic risk. There is another risk, the inflammatory risk. A low-grade inflammation on the long term is also detrimental to our vessels, and that had been shown in different studies. I really like the study Jupiter. I may mention it later on. But that's another one, HSCRP, and this one is not done routinely within your labs, and the same for the three first ones. And then my last reference to the spaghetti western is for a few dollars more. I will mention homocysteine. And why for a few dollars more? Because that's what it takes to fix it, only a few dollars. So I think we're done with the Clint Eastwood references. So what do we know about South Asian and those markers? So remember the ApoB as in bad seems to be superior to LDL or non-HDL cholesterol to estimate the cardiovascular risks. That was in debate 10 years ago, but I think now we're getting to a consensus. The ratio ApoB, so bad one and good one, A1, is the strongest association with the risk of heart attack among Asian and non-Asian. I'm also aware that it's a really good predictor for young South Asian, but that's an article I read a while ago and I couldn't find it anymore. LPA, so unfortunately LPA, it's something we get through our genes. It's not something we can modify with exercising or anything. You remember I mentioned you three of the effects of LPA in terms of plaques, inflammation, and thrombus. It does also not only increases the cardiovascular risk, if it's elevated, increase the risk of atrial fibrillation, but also aortic stenosis. There's still some question on his role on chronic kidney disease and other conditions. And we're not exactly sure why we have it. The physiological role of LPA is not well established. It does vary. The distribution of LPA is not a normal distribution. It's screwed in, and it's different populations. So this is the Interheart study, the one you saw from before. South Asian people with or without MI. So that cases with MI and without cases, it controls. And you see South Asian that had an MI, the percentage of them that have an elevated LPA, it's 18%. When control, it's only 8%. And that's a strong association. It was in this study, it has not been shown in different populations, probably because of lack of power of the study, but at least in South Asian, there's a clear association between elevated LPA and MI. That's just one way to look at it. Again, Interheart study. So here they're looking at the association between LDL and ApoB, so that's for one, LDL and ApoE, and HDL and ApoA1. So remember, LDL used to be the bad guy, and HDL used to be the good guy. So when we compare the new bad guy with the old bad guy, we see a linear relation. So as your LDL, someone's LDL increases, the ApoB concentration amount increases too. But all populations are not equal. So the one that had the highest amount of ApoB for one given LDL are the South Asians. So ApoB, remember, B as in bad. And in a mirror way, the one that has the lowest ApoA1, so the one you want to have in excess, for any given HDL, the lowest one are also the South Asian. So compared to the other ethnicities or ancestries, the South Asian have more ApoB and less ApoA1 for any given LDL or HDL. So a bit misleading HDL, just doing LDL HDL can be a bit misleading. So I think we reviewed pretty fast the lipidic risk. Let's talk about the inflammatory risk. The HSCRP, the high sensitivity C-reactive protein. So the median HSCRP, that's one of the study I found in South Asian people, was 2.63 milligram per liters. Ideally, you should aim at something below 2. In addition to this, an increase from 0.7 to 3p58 of HSCRP corresponds to an increase of 4 times of the risk of coronary event in South Asian people. So significant markers that should be done. The other risk for a few more dollars, the homocysteine. So homocysteine has been shown to be lower, at least in one cohort in India, when up to 75 people have low homocysteine and along with a low B12. B12 homocysteine, they need each other. There is a metabolism of homocysteine needs B12. There is a clear association between elevated homocysteine and cardiovascular event, but also Alzheimer. Yeah. So as you know, in some countries in South Asia, being vegetarian and low B12 intake, it can be prevalent. So that's something that is worth checking on, making sure the homocysteine doesn't run too high. There is no clear cutoff. 11, 15, those two good numbers as a cutoff. Yeah. So it should be below. So now a big question that we don't have an answer to yet, calcium score. So before we were just looking at blood test, and now we're going to look at something more personalized. It's a CT scan of the heart of the patient. So it really shows us exactly what's happening within someone's heart. The calcium score, it's called this way because the plaques, when they form in the coronary arteries, with time they can calcify. It's a stabilization process, but the more calcium one has, the more plaques they have, and the higher the cardiovascular risk is. So it's a pretty easy test to do. It's pretty fast. It takes 10 minutes. And what we know about calcium score and South Asian, there's different studies, five or six I found, and they don't all agree on the outcomes. Whether it starts at an early age or not, the same age as a Caucasian person, whether it goes higher or not is different. But what I found, and I think could be shared with you, is that for 2 diabetic patients, one from South Asia and one from with European ancestries, the calcium score will be higher in the South Asian patient. From the MASLD study, if we follow up people with a negative, like a calcium score of 0, we follow up on 5 years, and I think they were middle age. The rate of conversion in South Asian, that means going from 0 to something, is much higher in South Asian than the rest of the population. I think it was 23 for South Asian and 9% for European descent people. There's also, from MASLD study, a strong risk of severely increased calcium score for family history, for patients from South Asia with a family history of early coronary artery disease. And the last data point I want to mention, and this one has nothing to do with South Asian, it's true for all of us. Anybody with a positive calcium score at a young age does have a dramatical risk of cardiovascular event within 12 years and also early death. So detecting early on someone with a positive calcium score is very fundamental. 12 years goes fast. All right, now I want to give some silver lining after so many data that could be a bit stressful. I want to show something. So that was a study again from South Asian versus other countries. And when they look on the left-hand side, you see the 2 columns on the left-hand side, there's a probability of having a heart attack before the age of 40. And, you know, in South Asia, it seems to be close to 8%, when the rest of the world close to 5%. But when it's adjusted for different things, such as like smoking, blood pressure, diabetes, hip waist to hip ratio, which is a marker of visceral obesity, also the ratio ApoB, ApoA1, low dietary intake of fruit or vegetables, low physical activity, alcohol consumption, stress. When it's adjusted for all those factors, then the risk becomes really close to the rest of the world. So that means there is a big chance that all we're seeing in South Asian could be modifiable, not necessarily something that cannot be avoided. Eating better. And I'm not going to talk about diet from South Asian countries because first I don't know all of them, but and it will take too more time. But for what I've seen, less carb and more vegetables could be a good thing. And I'm sure Anna will be in agreement with me. So to summarize, what to ask in terms of cardiovascular risk to my doctor next time I see him. So again, with your annual visit check, do the lipid profile fasting, at least for the triglyceride, remember. If your insurance covers ApoB and ApoA1, do ApoB, ApoA1 at the same time. HSCRP and homocysteine, as far as I can tell, it's usually covered. And once in a lifetime, because remember genetic, do your LPA or LP small a. Some people call it this way most of the time. The LPA, if it's not covered by insurance, for example, my insurance said it was an experimental test. It was discovered 52 years ago, so the experiment is ongoing apparently for them. In that case, what you can do, you can get it done at a different, without insurance, at a different lab. There's some companies that do out of the pocket, and getting an LPA costs about $25 in 2025. So that's something you can do. You do it once. And what to do once those tests are done, the follow-up, I'm going to continue with the LPA. If the LPA is elevated for one patient, and that's true for all of us actually, check on your parents, check on your brothers, your sisters, check on your kids, because it may have been passed on to different generations. And then let's go back to the left corner. After doing everything, the fasting lipid profile, ApoB, ApoA1, HSCRP, homocysteine, you could consider a calcium score. So some guidelines say consider calcium score as early as 35 in South Asian. I agree with that. I think it's a good time to start at 35. Most of the calcium score I paid out of the pocket. Again, 2025 in the Bay Area, the price is around $120 to $150, $156. So I think that's a good investment. It's out of the pocket. That's one of the best investments anybody from South Asian ancestry could do at the age of 35. If, of course, there's some enhancing risk factors, such as like family history or diabetes, smoking, or early coronary disease in the family, then I would even consider doing it earlier, like between 30 and 35. So any South Asian, I would say between 35 and 40, I would start with the calcium score, just at least for a baseline, knowing that at this age, it is expected to have a calcium score of 0. And it's really to detect the one that already have a positive calcium score, and then and you remember that's a negative marker and a strong marker of increased cardiovascular risk within 12 years, so quite fast. So let's go back to my calculators. So once you've done all your blood testing and everything, QRISK 3, that's again the one from the UK, gives you the risk of heart attack or stroke within 10 years. I think that the one that the best tailored to South Asian people as of now. Back in India, I think back in, was it Sri Lanka, I forgot, or Bangladesh, they tried to adjust some of the calculators we have in the USA based on the population, the data they have on their own population. But I think this one is the best one so far. He also calculates a lifelong risk, and I really like it a lot. You can also play with it. If you're from South Asia and you have your numbers, do this one and do the PC or the Prevent one from the USA. And if you're middle-aged, like let's say 40, 45, you see the risk reported by the calculator from the USA, which say, let's say 3%. When the QRISK 3, we most likely will give you an increased risk by doubled, 6. And you see, it does the QRISK 3 does also include things that are not included in Prevent. Yeah. Two other tests I like to do, the MASLD score and the LPA. So the LPA says everything. It's a calculator that includes LPA. The MASLD, I like it because it includes the calcium score. Those are not specific to South Asian people, but the way to use them is by using your numbers and adding, for example, the calcium score of 50, you can see the effect on your cardiovascular risk. So the delta is important. Let's say if it increases your cardiovascular risk by 20%. So they give you an idea of what's going on with you. And same for LPA. LPA also give a risk of stroke or heart attack at 80 years of age. So it's a really nice calculator, but also use this one as a delta, not as an absolute number. If you want to have an idea of the absolute number, I would use Curie 3, but otherwise the MESA LPA for the delta. All right, so we're getting close to the end. I'm going to be fast. So I'm from South Asia. I'm 30, 35. What should I ask my doctor? Yeah, if indicated, remember, make sure you don't have any fatty liver and fibrotic fatty liver. That would be number one. Number two, diabetes. Check for diabetes. Don't hesitate to do an OGTT if you're borderline or to ask for it. You can run other calculators, but take it very seriously. There's some guidelines with pre-diabetic where they recommend metformin. Actually, pre-diabetic based on A1C may not be enough. The patient may already be diabetic, so there will be another incentive to start early on metformin. And have a complete cardiovascular assessment, including LPA1C in a lifetime. Consider calcium score. It's easier to start early on to prevent than to go to the cath lab for a stent. So that's the whole idea of the talk today. And just to summarize, I know there's a lot of information. I always try to make it more simple, but well, that's the best I could. So insulin resistant, do A1C, fasting glucose, fasting triglyceride. Liver fibrosis, you do liver enzyme CBC. Cardiovascular, fasting lipid, LPA once in a lifetime, ApoB, ApoA1, HSCRP, homocysteine. Consider calcium score after 30, 35. And then do your math. Math with Q diabetes, triglyceride glucose index, FIB4 score, Q is 3, MESA score, LPA score. And if someone wants to get, and I do that with my patient, I do many of the calculations. I can tell you they're very happy with the result, but it's really time consuming for us, that's for sure. Questions? Thank you very much.
Wow. Well, thank you, Dr. Skhiri. That was so informative, and it really provided some great resources too, putting the information in people's hands. Is there any questions out there? I see a lot of smiley faces.
The idea of the presentation is, as you said, Anna, it's really to give people the tools to ask for the right thing. You know, so often I see people going on Google and asking me for irrelevant labs or asking me for CRP instead of HSCRP. I mean, with this presentation, I think you have all the important labs to request them and explain why you need them. And you have also the tools. All the tools I gave, the calculators are online. There's no special login. Anybody can use them, and they can do the math themselves.
That's wonderful. I see a lot of hands raised. Can you just put them in the chat so that we can, will we get the slides? Yes, you will get the slides. We will send Dr. Skhiri's slides, as well as by next week, this presentation will be in our video library so you can view it again, because it's power-packed full of information. And I know that I will review it, and I think that this is such a useful tool. I'm not sure if we've ever had something like this on our webinar before, so this is wonderful.
Thank you.
I have another one. What can patients do to reverse fatty liver disease?
Oh, it's such an easy question. And I'm more embarrassed to say it. It's exercising and losing weight. So, but that would be for the MASLD, the one that's related to metabolic disorder, dysmetabolism or metabolic syndrome. You call it the way you want. There's a new medication that came on the market not long ago that can help too, but it's always losing weight and exercising. And losing weight is by eating better. And the food we eat, I mean, that was part of my presentation in November. The food we have now in modern countries doesn't look like food anymore. There's major components that are missing, and that's why we see all this obesity pandemic and fatty liver. Fatty liver is becoming the first cause of liver transplant in the USA, in the developed countries. It's just incredible to see what's happening. When I started medicine, type 2 diabetes was only for the adult. Now nobody is surprised to see a kid of 12-year-old, and Anna, you can confirm that, 12-year-old with type 2 diabetes, nobody's surprised anymore. 25 years ago was like, what's going on? This is not possible. I don't even think we had a term for it at this time. So things are changing, and I think it's environment, but food big time. Then for fatty liver, it can be fatty liver for other conditions. They have some autoimmune disease and metabolism disease and things like this. But for the one with about metabolism, it's exercising, losing weight.
Thank you. And then here's another one. Is ALPA constant, a constant for entire life?
Yes and no. So it becomes constant after the age of 5. After the age of 5, it should be constant, slight variation throughout the life. And I think there's a slight increase at menopause. It can be affected by some other conditions, but someone healthy should have a constant LPA throughout their life.
Okay, that was really helpful. You got more. Do you recommend alternate day fastings for people with type 2 diabetes and no complications?
That I cannot answer this question. I really don't. That would be a question for you, Anna, actually.
Fasting, you know what? I would say talk to your primary care or diabetes specialist, because that has a lot to do with the types of medications you use in regards to, because they might need to adjust them so that you don't have a low blood sugar. How do you figure out which doctor will be sourced for me? Who is putting stats for South Asia populations in consideration?
So say it again. I didn't get that.
So I think they're trying to figure out which doctor would be assigned to them, who is putting in their considering their demographics, their labs based off of their ancestry, their ethnicity, their being South Asian.
So if I understand well, the question is what type or which doctor is aware of the ethnicities or the ancestries of their patients. I hope all of us. I hope all of us. You saw me, I was sensitized to South Asian, but also you see, could have been to Filipino, people of Filipino ancestry. What is missing? I mean, there's one thing to be aware of the different conditions. The other one is to know or to have the tools to do it, or just the knowledge. I think everybody should be aware of their own ancestry and see what they are at risk of. And it's not only the ancestry, it's also the family. If there's cancers running in the family or things like this, this is really important to communicate. Communicate to the doctor what you know about your own family, and maybe ask directly, listen, I am from, I don't know, I'm from Chennai, I am from Mombasa, and what do you think I should be doing differently? I'm vegetarian, or things like this.
Yeah, you can also
poke the doctor. Yeah, that would be my best answer.
You can actually ask if they specialize in this area. I'm gonna chime in on that one too, because sometimes that is answered. What are your thoughts on the use of Ozempic type drugs for people with type 2 diabetes and fatty liver and CVD, cardiovascular disease?
Yeah, so the data, it's Ozempic, diabetes, and fatty liver. That's the question.
Mm-hmm.
Yeah, I mean, so it's two answers. The first answer, it's Ozempic and diabetes. Yeah, it works great. Yeah, it's amazing. It gives some protection, cardiovascular protection. It gives also some renal protection. It's great. It's a great medication. Fatty liver, we had different studies. And again, the MASLD, the fatty liver from this metabolism. We have some data were not conclusive. When the result was a bit surprising, I think there's a new study that came out that saw the fibrosis regress and the inflammation can regress. So I think we're moving to the right direction. That's what, as far as I know, yeah, that's some data from a month or two ago.
And then we have another one with an elevated lipoprotein of 80 and CT of chest calcium buildup negative. When would a person retest to check that?
So LPA, we don't retest. It's once in a lifetime.
Mhm.
Calcium score, it depends. It really depends on the risk. Repeating at 5 years, that's a good average. But you have to look at the big picture. You know, if the person is an athlete, skinny, no diabetes, no nothing, I say, okay, fine, 5 years should be good enough. But if the opposite, someone overweight and a smoker, etc., say maybe let's do 3 years. But maybe I also do more things than just that. I like to look at the big picture and have all the data I can in terms of A1C and ApoB, ApoA1, HSCRP. I like to have the big picture before I give a recommendation. So it's hard just to answer like this. I mean, there are many things are missing, but I think 5 years, 5 years will be maybe a maximum.
Wow, that is really, this has been helpful. Everyone says thank you.
Mhm.
Oh, wait, here we go. We have one more. Last
I have
one, we're
time.
at time.
I
Okay.
have time. I have time.
If someone had an elevated fatty liver and liver enzyme for a few years, but becomes normal recently, is there a supplement that you would recommend to protect high-risk fatty liver individuals?
So the fluctuation of the liver enzymes doesn't mean anything. Can have even a fibrosis or even cirrhosis with normal liver enzymes. Same for steatosis. So I'm glad the liver enzyme went down, but it doesn't mean the patient, I don't know if it's a particular case, but it doesn't mean that there is no fibrosis and the steatosis has regressed. In terms of supplement, yeah, they have a bit of vitamin E, like some weak data on vitamin E, and I forgot the other ones. Can try. I forgot the dosage on vitamin E. I think it was over 2 years. But really, again, the best way to take care of MASLD, beside the new medication on the market, it's really to exercise, eat well, and lose weight. And if the fibrosis level is too high, is to see a specialist. But then in order to establish the level of fibrosis, they have to do a fibroscan if the FIB4 is greater than 1.3.
Yeah, that's really helpful. That okay, one more. Here we go. Are
One
you good
more.
for one more?
Hey, I'm going to charge after 6 p.m.
Um, individual with pre-diabetes and uses a blood glucose meter to monitor levels. And numbers are fluctuating from 200 to 50 to 50 to 200. What is your recommendations? Shall I start medication?
Well, that's a specific case. And
Yeah,
frankly, I don't address specific cases.
yeah.
Uh, um, I'm assuming it's this person is talking about the continuous glucose monitoring, right?
Yeah, it's
Yeah.
not continuous. It's free blood glucose meter. Can I
Oh, the
take?
glucose meter.
Yeah,
Yeah, no. If I were you, I would talk to my family doctor.
right. And I'm just going to chime in. The blood glucose meters often have a reference range. So I would actually contact my primary care doctor and get an A1C. That's what we would do in the diabetes care program in primary care. That's yes, Dr. Skhiri, yes, because you want to make sure your blood glucose meter is reading accurately, and that's a wide range. But thank you for asking that question. Well, we've gotten a lot of thank yous and a
Oh,
very
thank
big
you.
thank you. And
Well,
we
I
will,
hope I hope I'll be helpful to some. I wanted to give back to my patients from 6 years. What they gave to me, I wanted to give it back to them.
yeah, you definitely learned a lot and shared it with us and really been very helpful. We're gonna have this posted. We appreciate you, Dr. Skhiri, taking the time and doing such a beautiful presentation. We appreciate everyone else coming. Thank you.
Mhm.
And the questions, wonderful questions. So we will be sending the slide deck out early next week, and it should be posted late next week on the Stanford wellness webinar in the health library. It's our diabetes wellness webinar. So thank you so much.
Thank you all for your attention and your time.
Okay. Yes.
Thank you.
Thanks.
Bye-bye.
Bye.